Hi all, welcome to RAAONLINE. Today we are going to deal with one important disease that acts as a social burden and has widespread economical impact, that is hypertension. Hypertension is commonly known as a silent killer because most of the time the patient will be asymptomatic and well compensated. Hypertension is identified as one of the major risk factors for cerebrovascular and cardiovascular accident. This blood pressure is a product of systemic vascular resistance and cardiac output. This cardiac output is determined by heart rate and stroke volume. So, any disease process which affects the heart rate, stroke volume and systemic vascular resistance will alter your blood pressure also. Coming to the history, hypertension is one of the oldest disease of the mankind. It is even documented in 2600 BC in the Chinese Hello Emperor Classic Book of Medicine, where they mention hypertension as the heart pulse disease. And for this treatment, there are two types of treatment, one from the Chinese and another from the Asian Greece. Leeching was done by Asian Greece and acupuncture was done by Chinese, and this shows acupuncture on one side and leeching on the other side. Even phlebotomy was also used as a management for this heart pulse disease. And in 1550 BC, in a book Heber's Papyrus, they have shown that this heart pulse disease affects the heart and brain. So, they have shown that hypertension affects heart and brain way back in 1550 BC. And the modern measurement of hypertension always started with William Harvey, who discovered the circulation of the blood in 1628. The first recorded blood pressure was made in 1733 by Stephen Hales, where he measured the blood pressure of the horse by a mercury manometer. The first recorded measurement of blood pressure in man was made by an Italian physician, Rivarocchi, in 1896, but he could measure only the systolic blood pressure, and the measurement of systolic and diastolic was possible with Korotkov sound, which was discovered by a Russian physician, Nikolai Korotkov, way back in 1905. Thereafterwards, you can see the routine BP measurement happening, end organ complications, newer antihypertensive therapies and the formation of guidelines in the last century. Now, coming to the definition. What is the definition of hypertension? It is defined as that level of sustained blood pressure in the arteries which over a period of time can cause end organ damage, particularly kidneys, your eye, brain, heart and the vascular system. What are the various types of hypertension? It is mainly two types. One is essential hypertension and another is secondary hypertension. Secondary hypertension will have a cause and primary hypertension doesn't have a cause. And most of the time, 95% of the cases, it is going to be essential or primary hypertension. The factors which contributes to this primary hypertension includes obesity, insulin resistance, high alcohol intake, high salt intake, elderly age groups, sedentary lifestyle, stress, low potassium intake and low calcium intake. Coming to secondary hypertension, where there is a causative factors, it might be renal disorders like chronic pyelonephritis or diabetic nephropathy, where your renin angiotensin system comes into picture. Your vascular disorders like coarctation of aorta or atherosclerosis can cause hypertension. Endocrine disorders, primary hyperaldosteronism or pheochromocytoma. Drugs like alcohol intake and cocaine can cause hypertension. Miscellaneous causes includes scleroderma and obstructive sleep apnea syndrome. And hypertension can be also benign and malignant. Benign means your blood pressure is stable and there is no end organ damage. With your medication, you are keeping your blood pressure well under control. Then what is malignant hypertension? Here, exceeding of blood pressure regulation, there is a compensatory mechanism which happens in the arteriole which is exceeded, and there is capillary hyperperfusion leading to reversible capillary leakage. This leads to papilledema and retinal hemorrhage in the eye, cerebral edema in the brain, proteinuria in the kidney, and also an acute left ventricular failure in the heart, and the atherosclerosis in the vascular system is also accelerated. Now coming to different terminology with regard to hypertension. What is isolated systolic hypertension? Here, your systolic blood pressure is greater than 140 millimeter of mercury, but the diastolic is less than 90 millimeter of mercury. You have only isolated systolic going up. This happens commonly in elderly population. Coming to resistant hypertension. Here, you fail to reach the target blood pressure. For example, your target blood pressure is around 140 by 80. You are not able to reach that pressure in spite of using 3 drugs regimen. That is resistant hypertension. Coming to uncontrolled hypertension. Here, the blood pressure is above the recommended level. You are not able to control the blood pressure to the recommended level during the perioperative period or even in the normal timing. Coming to complicated hypertension, here hypertension is associated with other comorbidities like diabetes or pheochromocytoma or some other comorbidities which can accelerate your hypertension. That is complicated hypertension. Now coming to the various category of hypertension. Optimal blood pressure is your systolic is less than 120 and your diastolic is less than 80 millimeter of mercury. That is the optimal blood pressure. Now coming to elevated blood pressure, your systolic blood pressure is between 120 to 129 millimeter of mercury and your diastolic is normal, less than 80 millimeter of mercury. Coming to stage 1 hypertension, here your systolic blood pressure is between 130 to 139 millimeter of mercury and your diastolic pressure is between 80 to 89 millimeter of mercury. If one of this factor is present, it is stage 1 hypertension. Coming to stage 2, your systolic is greater than equal to 140 millimeter of mercury or your diastolic is greater than equal to 90 millimeter of mercury. Coming to hypertensive emergency or crisis, your systolic is greater than 180 millimeter of mercury and your diastolic is greater than 120 millimeter of mercury. These are all various categories. Now coming to the stages and grades of hypertension. The stages include stage 1 which is uncomplicated, stage 2 is asymptomatic disease and stage 3 is established disease. In stage 1, you don't have any other risk factors contributing to hypertension. Otherwise, you might have 1 or 2 risk factors or you can have greater than equal to 3 risk factors. This stage 1 is subdivided into 3 subcategories. In stage 2, here you have hypertension mediated organ damage or you have a chronic kidney disease which is grade 3 or diabetes mellitus without organ damage. In stage 3, you will have established cardiovascular disease, chronic kidney disease which is greater than 4 and or diabetes mellitus with organ damage. These are the various stages of hypertension. You have uncomplicated, asymptomatic and established disease. The stage 1 is subdivided into other 3 categories. In stage 2, you don't have any organ damage but the chronic kidney disease can be grade 3. In established disease, the chronic kidney disease will be greater than equal to 4 and there is diabetes mellitus with organ damage and you have established cardiovascular and kidney disease. Coming to BP grading, high normal, your systolic is between 130 to 139 and your diastolic blood pressure is between 85 to 89. In grade 1, your systolic blood pressure is between 140 to 159 and your diastolic blood pressure is between 90 to 99. In grade 2, your systolic blood pressure is between 160 to 179 and your diastolic blood pressure is between 100 to 109. And in grade 3, your systolic blood pressure is greater than 180 and your diastolic blood pressure is greater than 110. With these stages and grading, what risk you put for patient with hypertension coming for surgery? If it is in stage 1 with no risk factor and high normal, the risk is low. If it is in stage 1 and grade 1, it is also low risk. In stage 1 with 1 or 2 risk factor and high normal blood pressure, again it is low risk. Now coming to moderate risk, when you have grade 2 with no risk factor or you are in grade 1 with 1 or 2 risk factors or you have 3 or more risk factors which is in stage 1, it is moderate risk. Now coming to high risk. Whenever it is grade 3, it is high risk, or a stage 2 where there is chronic kidney disease greater than grade 3. If it is grade 1 or grade 2 also, it is high risk. Then where is very high risk? Whenever you are in grade 3 and stage 3, it is very high risk. Now coming to the prerequisite for measuring blood pressure in the preoperative period. You should take the average based on greater than 2 readings obtained on more than 2 occasions. You should ask the patient to rest at least for 5 minutes. The patient is seated, feet on the floor and arm at the level of the heart. And what is more important is you should have an appropriate size curve which covers at least 80% of the arm. Now coming to the blood pressure regulation. Blood pressure regulation usually, as I said earlier, anything which affects the heart rate, stroke volume and systemic vascular resistance will alter your blood pressure. So the main compensatory mechanism comes from the vascular system which is responsible for the vascular resistance, your brain which secretes vasopressin, your kidney which secretes the renin, and apart from that, the sympathetic nervous system plays a very big role in controlling your blood pressure. Let us look what happens if the pressure drops and how body compensates to increase your blood pressure. Whenever there is a fall in blood pressure, your baroreceptor is activated. This baroreceptor is located at the arch of aorta and the internal carotid artery. Whenever your blood pressure drops below, mean arterial pressure drops below 60 mm of mercury, this baroreceptor is activated. Your sympathetic is stimulated and there is decreased parasympathetic activity. Your heart rate contractility goes up, your systemic vascular resistance is increased and this will increase your blood pressure. This is the first compensatory mechanism which happens whenever there is low blood pressure. Now coming to the chemoreceptor reflex. This becomes important when your mean arterial pressure falls below 60 mm of mercury when the baroreceptor reflex is already exhausted. Here the acidosis which happens with decreased organ perfusion stimulates the chemoreceptors. This chemoreceptors is located in the ascending aorta and the internal carotid artery where the carotid body is located. On stimulating this chemoreceptor, there is sympathetic activation. Not only that, the stagnant hypoxia causes peripheral vasoconstriction which increases your SVR2. Now coming to the most important mechanism which maintains the blood pressure, that is renin angiotensin system which is coming from your kidney. Whenever there is reduced cardiac output, decreased renal perfusion, hypovolemia or decreased sodium intake which decreases the blood pressure, there is renin activation. As the first step, the angiotensinogen is converted to angiotensin 1 by renin. This angiotensin 1 is converted to most potent vasoconstrictor angiotensin 2 by the angiotensin converting enzyme, and this angiotensin 2 acts on angiotensin 2 type 1 receptor and it also leads to increased aldosterone production, which increases your sodium and water resorption. It also helps in the stimulation of vasopressin release from pituitary. It also stimulates the sympathetic nervous system, thereby your noradrenaline is released. So, what are the different ways to increase the blood pressure? Everything is done by angiotensin 2, and here you can see the blood pressure is increased mainly with angiotensin 2 is such a potent vasoconstrictor. Now, coming to the targeted blood pressure in the operating room. According to AHA, for most patients with hypertension, including patients with stable cardiovascular disease, chronic kidney disease, diabetes mellitus and age-related issue, the target blood pressure in the perioperative period is 130/80 millimeter of mercury. Now, coming to various factors which affects the blood pressure control. There are commonly used medication which can either increase or decrease your blood pressure. Non-steroidal anti-inflammatory drug, your oral contraceptives, corticosteroids, various sympathomimetics which are present in the cough syrup, antidepressants, tricyclic antidepressants, serotonin and norepinephrine retake uptake inhibitors, monoamine oxidase inhibitors. Coming to recreational or illicit drugs, you have alcohol, caffeine, amphetamine and chewing tobacco. Apart from that, there are significant predictors of non-adherence to antihypertensive medication. This includes young population, age less than 50 years, male gender, Hispanic or African or American, low family income, no health insurance or no medical visit within the past year. Now, coming to the pathophysiology. Here, you have increased blood pressure. Your pressure in the artery is high. In the brain, there is sympathetic activation and thirst is stimulated. In pituitary gland, your vasopressin is increased. In heart, there is increased inotropic effect, chronotropic effect and concentric hypertrophy. And coming to the kidney and adrenal, there is going to be water retention, aldosterone secretion, sodium reabsorption, efferent arteriole vasoconstriction and catecholamine release. And with the vascular system, there is vasoconstriction, vascular growth, inflammation and platelet aggregation. Now, coming to end organ damage, with regard to the vascular system, there is going to be endothelial dysfunction, remodeling which happens within the arterioles, generalized atherosclerosis, atherosclerotic stenosis of the aortic valve and even aortic aneurysm can happen. With regard to cerebrovascular damage, there can be acute hypertensive encephalopathy, stroke, intracerebral hemorrhage, lacunar infarction, vascular dementia, retinopathy and papilledema. Coming to heart disease, as I said earlier, there is going to be concentric left ventricular hypertrophy, arrhythmias can happen, particularly atrial fibrillation, coronary artery microangiopathy, coronary artery disease, myocardial infarction and heart failure can develop. Coming to nephropathy, there will be albuminuria, proteinuria, chronic renal insufficiency, finally renal failure can happen. So, coming to the management of hypertension. First line recommendation, non-pharmacological, you have to go for a lifestyle modification. Weight loss is very imperative to control the blood pressure. You have to increase your physical activity and go for diet modification. Coming to acute antihypertensives, which will be very handy in the perioperative period. Beta blockers, here you can use labetalol or propranolol, which reduces your vascular resistance and get your pressures down. Glyceryl trinitrate, it reduces the blood pressure by venodilatation. Alpha-2 blockers, clonidine or dexmedetomidine, relaxes your vascular tone, reduces your SVR. Vasodilators, hydralazine, also causes vasodilatation. Similarly, your alpha blocker and calcium channel blocker also causes low blood pressure by vasodilatation. Coming to long-term hypertensive, thiazide diuretics, here you have brendrofluozide or entopimide. Apart from causing diuresis, they block the sodium channel. Beta blockers, you have atenolol, propranolol or esmolol. It slows the heart rate, improve ventricular filling by blocking the sympathetic activity. Your ACE inhibitor, captopril, enoropril or peridopril, here it blocks the angiotensin converting enzyme. It helps in LV remodeling also. Coming to angiotensin receptor blocker, here you have losartan and candesartan. It blocks the angiotensin 2 receptor. Calcium channel blocker, you have amlodipine, which produces vasodilatation by blocking the calcium channel. When it comes to treatment, the first line of pharmacological treatment in uncomplicated stage 1 hypertension is either a thiazide diuretic or angiotensin converting enzyme inhibitor or ARB, angiotensin receptor blocker or a calcium channel blocker. Out of this 4 drugs, you will be taking one of the drug for uncomplicated stage 1 diabetes. In stage 2, the treatment typically extends to a 2-drug regimen. Here, you combine one drug with the beta blocker, one of these 4 drugs with a beta blocker, or you combine 2 drugs out of this 4. That is initial treatment of hypertension in stage 1 and stage 2. Now coming to mode of action of the various antihypertensive. This flow diagram you saw how the hypertension is maintained whenever there is hypotension. Now we have to get the pressure down, so all the drugs have to counter at each step to bring your blood pressure down. The first and foremost, your renin inhibitor acts on renin and prevents the conversion of angiotensinogen to angiotensin 1, and your AC inhibitors, angiotensin converting enzyme inhibitor, prevents the conversion of angiotensin 1 to angiotensin 2, thereby the vasoconstriction effect is prevented. And your ARB, angiotensin receptor blocker, prevents the action on angiotensin 2 on the receptor to cause vasoconstriction. So, all 3 renin inhibitors, IC inhibitors and your ARB acts on the renin angiotensin system to prevents vasoconstriction, and your aldosterone antagonist and thiazide and loop diuretics acts at the level of sodium and water resorption and prevents its resorption, thereby it causes more diuresis and volume is lost. And your calcium channel blocker and various vasodilators act on the blood vessels and prevent vasoconstriction. And the most important drug, beta blocker, prevents your sympathetic nervous system activation as well as prevent the renin angiotensin axis. So, you can see various antihypertensives acting at the different level to keep the blood pressure under control. Now, let us look at the various groups of antihypertensive. Coming to diuretics, you have thiazide diuretics. It inhibits the sodium and chloride transport and the site of action is early distal tubules. And coming to loop diuretics, furosemide, it inhibits the sodium, potassium and chloride uptake. It acts on the loop of Henle. Coming to aldosterone antagonist, spironolactone, it inhibits sodium resorption and potassium secretion. It acts in the collecting tubules. Coming to osmotic diuretics, mannitol, here it increases the osmotic pressure and inhibits water and solute reabsorption. It acts in the primary proximal tubules. Coming to carbonic anhydrase inhibitor, acetozolamide, it inhibits carbonic anhydrase which inhibits bicarbonate and reduces sodium reabsorption. It acts in the collecting tubules. And coming to triamterene, which is the sodium channel blocker, it directly inhibits sodium resorption and potassium secretion. It acts in the collecting tubule. Now coming to the anesthetic application of patient with hypertension being on a diuretic. in the first instance, they can mask the hypovolemia because these are all diuretic agent causing diuretics. So, it can mask the hypovolemia, which is a very common even in the perioperative period. Electrolyte imbalance. There might be sodium and potassium abnormalities which can be very disastrous in the perioperative period. Your neuromuscular blockade can be prolonged and it also alters the sugar control. Sometimes it can cause dangerous hyperglycemia. Coming to angiotensin converting enzyme inhibitor, there are three classes of angiotensin converting enzyme inhibitor that differ in potency, bioavailability, half-life and route of elimination. Class 1, it contains a sulfhydryl group. The classical example is captopril, which is a proline derivative. Coming to class 2, it is a prodrug. The classical example is enalapril. And coming to class 3, it is water-soluble lisinopril, which is a lysine derivative. This class 1, such as captopril, have the shortest half-life, okay, 6 to 12 hours, and it contains a problematic sulfhydryl group that can cause skin rash, loss of taste, neutropenia and proteinuria. In class 2, such as enalapril, they are prodrugs that are converted to active drugs in the liver, and enalaprillate is a parenteral form that can be administered to patient on ACE inhibitor in the perioperative period. Lisinopril is the only class 3 agent and it is not a prodrug and it is water soluble and excreted unchanged in the kidney without hepatic metabolism. These are the three classes. Based on the chemical structure, again they are divided into three groups. Sulfhydryl group is captopril. Your dicarboxylate group is enalapril, lisinopril and ramipril, and the phosphonate group is phosphinopril. What is the anesthetic implication of this ACE inhibitor? As I said earlier, captopril can cause dangerous bradykinin mediated angioedema, and cough in the post-surgical period can be really dangerous, and the most important thing is it can lead to refractive hypotension, particularly in surgeries like vascular surgery where hypotension is common. What is very important is, as put in the adjective, the hypotension can be refractory and won't respond to any of the vasoconstrictors. Coming to ARB, it's known as angiotensin 2 receptor antagonist. All the drugs ends with sartan. It prevents the binding of angiotensin 2 to the angiotensin 2 receptor, that is angiotensin 2 receptor type 1, which is located on the vascular smooth muscle. This prevention of the receptor attaching to angiotensin 2 decrease in peripheral vasoconstriction, thereby decreasing your SVR and thereby your arterial pressure comes down. What is very important here is the bradykinin level is normal. So, bradykinin induced angioedema is prevented with ARB. Here, the anesthetic implication is again refractive hypotension, and if you stop the drug, the chances of rebound hypertension in the postoperative period is very high. Now, coming to direct renin inhibitor, aliskerin, it binds to S3BP binding site on the renin and inhibits the conversion of angiotensinogen to angiotensin 1. So, it stops the renin angiotensin axis at the beginning only. So, all the side effects of ACE inhibitor and ARB are aggravated and could have similar anesthetic implication with direct renin inhibitor. Now, coming to calcium channel blockers, here you have diiropyridine, which is divided into three generations: first generation, second generation and third generation. The first generation drug includes nifedipine, the second generation is nicardipine and the third generation is amlodipine. Coming to phenylalkylamine, you have verapamil, and coming to benzodiazepine, you have diltiazem. And what are the cardiac effect of this calcium channel blocker, it decreases the contractility, it reduces the heart rate and a dromotropic effect. It decreases the conduction velocity also. Apart from that, the most important thing, it is a vasodilator and cause smooth muscle relaxation. Now, a comparison between various calcium channel blocker. Your diltiazem may not have any effect on the inotrope, but decreases your chronotropic effect. There is a reduced heart rate, peripheral vasodilatation can happen. The coronary vasodilatation is much more than the peripheral vasodilatation and there is no reflex tachycardia. Coming to verapamil, there is decreased inotropy, decreased chronotropy. The peripheral vasodilatation is less than the coronary vasodilatation and there is no reflex tachycardia. Coming to nicardipine, doesn't affect the inotrope or chronotrope, but there is significant peripheral and coronary vasodilatation and reflex tachycardia happens due to hypotension. Coming to nifedipine, it decreases the inotrope little bit, but there is significant coronary and peripheral vasodilatation and you can see a reflex tachycardia which is very prominent with nifedipine. Coming to clevidipine, here the inotrope is affected little bit and there is significant coronary and peripheral vasodilatation. Reflex tachycardia can happen but not up to the level of nifedipine. Coming to anesthetic implication of calcium channel blocker, here the inhalational agent decreases the availability of intracellular calcium, which in turn enhances the negative chronotropic, inotropic and dromotropic effect of calcium channel blocker. What you have to understand that the cardiac depressive property equals the vasodilatation. As vasodilatation happens to be good, your cardiac depression also will happen. The physiological blunting of expected reflex tachycardia can happen. See, for example, whenever there is a systemic vasodilatation, patient will get tachycardia due to hypotension. But with the anesthesia, you prevent the blunting of this reflex and the tachycardia may not happen. And calcium channel blocker can potentiate all neuromuscular blocking agent. It impairs HPV, hypoxic pulmonary vasoconstriction, and calcium channel blocker can cause mild increase in intracranial pressure. Another important concern with calcium channel blocker comes in when you treat malignant hyperthermia. Malignant hyperthermia, there is hypercalcemia, so you will think that calcium channel blocker are beneficial. But it will lead to cardiac collapse if you administer calcium channel blocker and dantrolene together. So, we have to be very careful to administer calcium channel blocker in malignant hyperthermia. Now, coming to alpha blockers. Here, alpha blockers can be selective or non-selective. Non-selective, again, it can be reversible or irreversible. Irreversible blockage of the alpha receptor. Reversible includes phenethylamine and tolozoline, and irreversible is phenoxybenzamine. And coming to selective, it blocks selectively the alpha 1 receptor or alpha 2 receptor. Selective alpha 1 receptors include prazosin and doxazine, and alpha 2 blockers includes hogimil, and miscellaneous alpha blockers includes ergot alkaloids. This alpha blockers acts on the alpha receptors, therefore prevent the release of catecholamine and prevents the response at the level of peripheral vasculature and the heart. Basically, it decreases the systemic vascular resistance, but it is seldom used as first line therapy. Your side effect includes reflex tachycardia, orthostatic hypotension and fluid retention. Now, coming to few common alpha blocker, prazosin, it is used in benign prostatic hypertrophy. Coming to phenethylamine, it is used commonly in hypertensive crisis which is associated with pheochromocytoma along with beta blocker. Both combined will decrease the increase in heart rate. It is also used in dentistry where the reversal can happen more accurately. It limits the duration of soft tissue anesthesia. How it does it? It promotes a local vasodilatation, thereby accelerates the systemic uptake of local anesthetic. Thereby, the local area will be reversed of anesthesia. Now, coming to the most important group of drug which have widespread perioperative implication, that is beta blockers. These beta blockers are divided into three major groups: non-selective beta blocker, or selective where they act on beta 1 or beta 2, or alpha, it blocks the alpha also in addition to the blocking of beta receptor. This non-selective can be further subdivided into whether they have intrinsic sympathomimetic or there is no intrinsic sympathomimetic activity. The drugs without intrinsic sympathomimetic activity includes nadolol, propranolol, timolol and sotalol. The drug which has sympathomimetic activity includes pindolol, cortisolol, penbutalol, allopurinol and oxypurinol. Now coming to selective, again it can be divided with whether they have intrinsic sympathomimetic activity or not. Those without intrinsic sympathomimetic activity includes your commonly used drug atenolol, esmolol, metoprolol, bisoprolol and beta-xolol. Coming to the drug which is selective and as well as having intrinsic sympathomimetic activity, that is acebutolol and celiprolol. Now coming to the drugs which have alpha as well as beta activity, this includes labetalol, busididolol and carvedilol. Labetalol and carvedilol are the most commonly used drugs. Now coming to the common properties of the commonly used beta blocker. Your esmolol decreases the heart rate significantly. Your mean arterial pressure comes down. It is a beta 1 selective drug. The onset happens within 2 minutes and the duration of action is between 10 to 30 minutes. Coming to labetalol, it decreases the heart rate. It decreases the mean arterial pressure more than the heart rate. It acts on alpha as well as beta. The onset takes place within 5 to 10 minutes and the duration can be between 2 to 8 hours. Metoprolol, it decreases the heart rate, it decreases the blood pressure. It is a selective beta 1 antagonist. It acts within 1 to 5 minutes, but the peak action is at 20 minutes and the duration of action is 5 to 8 hours. Coming to propranolol, it decreases the heart rate, it decreases the blood pressure, but it is a non-selective. It acts on both beta 1 and beta 2. The onset happens within 2 to 10 minutes and the duration is 6 to 10 hours. Coming to anesthetic implication of beta blocker. If you withhold beta blocker, significant rebound hypertension and tachycardia can happen, which can lead to myocardial ischemia or infarction in the perioperative period. But if you continue, there is increased risk of bronchoconstriction and sometimes in bronchospasm you use beta 2 inhaler, and by giving beta blocker it can be counterproductive, and beta blockers are known to cause bradycardia and orthostatic hypotension. They can be atrioventricular conduction delay. It can mask the hypoglycemia which happens with antidiabetic agents. Another important thing is you are giving beta blocker when the heart rate may not go up. So the effect of surgical stimulation, that is increased heart rate, is prevented, which makes you think that the patient can go for less opioid, that is opioid sparing effect. It is good in one way, but the negative side of it is you might lead to subanalgesic or subanesthetic dose of the pain medication and anesthetics. Now coming to alpha 2 agonists. These alpha 2 agonists are known for sedative, anxiolytic and mild analgesic properties. They are divided into subtypes of 2A and B. These 2A and C are found in the central nervous system and play a role in sedation, analgesia and sympatholytic effect, while 2B are found on the vascular smooth muscle peripherally and have shown to mediate vasoconstrictive effect. So it is very important to this alpha 2 agonist mainly acts on 2A and 2C. And the most important alpha 2 agonists are clonidine and dexmedetomidine, and they differ in their selectivity for alpha 2 receptor. Dexmedetomidine has about 1620 to 1 for alpha 2 and alpha 1, whereas with clonidine it is 220:1. Tizanidine is another alpha 2 agonist. It is an antispastic, but it is mainly used in dental anesthesia community because there is less fluctuation in blood pressure and heart rate. Now coming to the anesthetic implication of alpha 2 agonist, if discontinued, it can lead to rebound hypertensive crisis. It can reduce your anesthetic requirement. It can be used for awake fiber optic intubation. It decreases the pre-op anxiety and emergence delirium in children. It can cause significant hypotension and bradycardia. Alpha 2 agonist can be used as an adjuvant in spinal and epidural anesthesia. Now coming to vasodilators. Vasodilators which are used to control the blood pressure decreases your afterload, preload or both. They also help in controlling the pulmonary hypertension too. The commonly used vasodilators include nitroglycerin, hydralazine and sodium nitroprusside. And the anesthetic implication of these vasodilators are mainly cyanide toxicity and methemoglobinemia, which is very common with sodium nitroprusside. They can be reflex tachycardia and dangerous hypotension. This hypotension will cause reflex tachycardia. Now coming to the summary of all the various group of drugs which is used in controlling the blood pressure. ACE inhibitors, they end with pril. The common example are lisinopril, enalapril or captopril. They inhibit the angiotensin converting enzyme, thereby decreasing your systemic vascular resistance and stroke volume by reducing tune pain parameter, which causes the increase in blood pressure. Coming to ARB, they end with sartan. The commonly used is losartan and valsartan. It blocks the angiotensin 2 receptor. Here again, your systemic vascular resistance comes down, your stroke volume comes down. Alpha blocker ends with hosin. The most commonly used is prazosin. It blocks the alpha receptors. It decreases the SVR. Coming to beta blocker, it ends with LOL. The most commonly used is metoprolol and labetalol. It blocks the beta receptor. Here, it reduces the heart rate and the stroke volume. Coming to calcium channel blocker, it ends with dipin. The most commonly used is amlodipin, nicardipin. They block the calcium channel and decreases the SVR. And coming to diuretics, it ends with furosemide and hydrochlorothiazide are commonly used. They facilitate diuresis and reduces the preload and the stroke volume. Now coming to the preoperative antihypertensive medication, beta blockers continue till surgery and continue into the postoperative period too. Calcium channel blocker similarly maintain until surgery. Coming to renin angiotensin system inhibitor, if hypotension is going to be a problem in the perioperative period, try to withhold the dose on the morning of the surgery. This type of surgery includes vascular surgery where hypotension is anticipated. But even in that case also, you have to restart the angiotensin converting enzyme inhibitor as early as possible. Coming to diuretic, here you maintain until surgery. Maybe you can stop on the day of surgery if you anticipate hypovolemia in the perioperative period. Now coming to the preoperative workup. The target organ affected is brain. Here the patient will have depression and seizure. Here you have to go for a neurologist's opinion and get a complete neurological evaluation done. Coming to your eye, the patient can have retinal detachment, hemorrhage or visual tortuosity. Complete ocular examination, fundoscopy should be done. Coming to heart and blood vessel, they can be concentric left ventricular hypertrophy or patient might have an acute left ventricular failure. Here you have to go with electrocardiogram, chest X-ray and echocardiogram. Coming to kidney, they will be azotemia or proteinuria. You have to go with blood urea nitrogen, creatinine and urine protein creatinine ratio. Sometimes ultrasound abdomen can be added to measure the size of the kidney. Now coming to electrocardiogram in patient with hypertension, the consistent finding is going to be left ventricular hypertrophy. And in chest X-ray, coming to chest X-ray, there can be a slight cardiomegaly. Usually concentric hypertrophy won't lead to a cardiomegaly on the X-ray, but sometimes you can find out cardiomegaly on the X-ray with hypertension. Now coming to echocardiogram, here in addition to assessing the systolic and diastolic function, the most important consistent finding you will be finding is concentric hypertrophy. You will have a kissing papillary muscle. Whenever you have a concentric hypertrophy like this, you should be very careful in maintaining the SVR. If you go for sudden sympathetic blockade, like give like a spinal, the hypotension fall will be really exaggerated. Your fall in blood pressure should be gradual. If you give sudden sympathetic blockade, the blood pressure fall will be excessive. Suddenly, blood pressure of 140 or 90 will come to 60/30 or something whenever a concentric hypertrophy is there. Now, coming to anesthesia effect with hypertension. As I said earlier, blood pressure is a product of cardiac output into systemic vascular resistance, and cardiac output is a product of heart rate and stroke volume. By giving anesthesia, all these three variables, systemic vascular resistance and heart rate and stroke volume is halted. You can give volume which alters your venous return and the preload, and your sympathetic system can alter the vascular tone, thereby decreases the pressure. Now coming to few salient point in anesthesia, there will be an exaggerated fall during induction and intubation response can be excessive. So care should be taken to avoid the intubation response. Try to maintain the pressure within 20% of the baseline. Both in hypo as well as hyper, you should maintain the pressure within 20% of the baseline. You should have adequate depth of anesthesia as well as adequate analgesia should be provided. Avoid light plane of anesthesia. Ketamine and sympathomimetics which can cause high blood pressure, if possible, should be avoided. And whenever you start a vasoconstrictor, the response will be exaggerated. So always think twice before starting a vasoconstrictor. Patient with hypertension are prone for diastolic dysfunction. So you have to be careful in the perioperative period, watching for left ventricular failure. And as I said earlier, concentric hypertrophy, you should be very careful when blocking the sympathetic system. To summarize, if patient is grade 1, your blood pressure is less than 160/100, you can proceed to surgery. If it is grade 2, the blood pressure systolic is around 160/80 and the diastolic is 100 to 110. Here, the first thing is you document in patient record. Talk to the patient, relieve his anxiety, also discuss with the surgeon. Okay, you can proceed with surgery, but see to that acute antihypertensives are available, and if needed, you have to go for advanced hemodynamic parameters like monitoring the cardiac output, preload and systemic vascular resistance. Coming to grade 3, where your systolic is greater than 180 and diastolic greater than 110, here delay the surgery unless it is a life-saving emergency. So coming to the baseline assessment, here look at the age of the patient. Elderly patients are mostly hypertensive. Look at the baseline BP and try to maintain the blood pressure within 20% of the baseline. And another important thing is you have to look at the history of hypertension. How long the patient was hypertensive and what was his status of control, whether the hypertension was controlled or it was uncontrolled. You look at the active cardiac condition like patient is having recent MI or severe valvular disease. Aortic stenosis or coarctation can have dangerous high blood pressures, low cardiac. Then look at pertinent medical and surgical condition. First is active cardiac condition. Recent MI, you might have a very low blood pressure. You have valvular heart disease. your aortic stenosis or mitral stenosis can have very low pressure, low cardiac output. Again, will have dangerous hypotension. Neurological lesion, ischemic, hemorrhagic or intracranial hypertension, which can lead to increased sympathetic activity. Organ ischemia of any type trauma, for example, bleeding, cardiac tamponade or traumatic brain injury, where blood pressure control is the most important thing, and sepsis, there might be a refractive hypotension. And you have to see what surgery patient is going to undergo, whether he is undergoing cardiac surgery with or without cardiopulmonary bypass, major vascular surgery, carotid or cerebral vascular surgery, or major non-cardiac surgery. Here, the blood pressure control is very, very important. Then you have to look for hazards of hypotension like organ ischemia, brain, heart, kidney, gastrointestinal tract, etc. And similarly, you have to look for hazards of hypertension, BP related bleeding. In the postoperative period, if you allow the blood pressure to go up, the suture might bleed or the stitches might give way in the internal organ. It is very common cause for bleeding in the cardiac surgery. Cardiac ischemia due to increased myocardial oxygen consumption afterload. As your pressure goes up, your LV-EDP goes up, your afterload increases and your myocardial oxygen consumption increases and patient will develop ischemia. Sometimes overzealous organ perfusion, particularly in the brain, it can be disastrous, and side effect associated with vasopressor use. Thank you.